I will present Dr. Kohler. He's a professor. No, he's not a professor. Sorry. He's a doctor at Eastman Dental Institute at University College London. Research has focused on optical diagnostics and photodynamic therapy for head and neck. Thank you, Professor.
Thank you very much. We just had a discussion for 10 minutes about the fact that I'm not a professor, I'm a surgeon. I feel like a slight fraud being in this august company of all these great scientific minds, because what I'm going to talk about is simple surgery. Surgery is a simple art form. If it wasn't simple, surgeons wouldn't be able to carry it out. So I'm going to go through a few illustrations of how we calculate drug dose, light dose, drug light interval, and how to actually apply PDT in a clinical setting. So we've heard quite a lot about the history, and this was another one of the very early cases with a rodent ulcer of the lip treated with PDT. I'm a head and neck surgeon. Why is head and neck so applicable to PDT? Well, I don't know if you caught Ron's comment earlier on. It's a loco-regional disease. People who get oral cavity cancer or head and neck cancer in general die of the local manifestations of their disease. They do not die quietly of multi-organ failure because they get metastasis. They choke to death, they bleed to death. It's thoroughly miserable, and Brazil has quite a big problem. We've seen the discussion about the different mechanisms by which it works. As a simple surgeon, it works in two ways: apoptotic cell programmed cell killing and vascular shutdown. The effects are very much vascular, which starves tumor of oxygen. We've also heard there are a number of drugs in clinical use. Most of my experience has been with Phoscan, although I've used these, all of these others apart from verteporfin. I will specify when I'm talking about some of the other drugs. Otherwise, most of this relates to the use of Phoscan, which in Europe is licensed for the treatment of head and neck cancer. And I'm initially going to be talking about surface illumination PDT. A lot of what we've heard already has been about surface illumination. So these are the requirements: light, drug, and oxygen. First generation sensitizers were around for quite a long time. The first modern PDT treatment was actually carried out by Lipson in London. It wasn't carried out in the States. It was Doherty who promoted PDT in the early parts of the early parts of the 70s and 80s. Photofrin is still in clinical use, but these others have fallen a bit by the wayside, and we're now really into the porphyrins, chlorins, and some of these other drugs. So, Phoscan is the drug, as I say, I've had most experience with. It's a very efficient generator of singlet oxygen. It's synthetic, so its purity is quite good. Low drug-light interaction achieve quite a significant photodynamic effect, and there's quite an intense absorption band in the red and good pharmacokinetics. Little or no toxicity in the absence of light, and that's very important. We talk about chemotherapy drugs, we talk about morbidity from other therapies. Timoporphyrin or Phoscan, and this is true of just about all of the photosensitizers, little toxicity in the dark. This is its absorption band. Now, it does have quite a big absorption band in the blue light region, but as we heard earlier, blue does not penetrate very deeply through tissue, and in fact, we use this band at 652 nanometers, which is in the red. This is the demonstration Ron was attempting to achieve by shining red light from a pointer. Green light doesn't penetrate, red light does. Now, we've spoken about type 1, type 2 photochemical reactions and all that sort of stuff. Really, There are lots of unrealistic claims made about PDT, about it being a selective effect. And this is very important as part of the PDT effect, and what actually happens, depending on which drug you use, the connective tissue framework is maintained intact after PDT. So here you can see with photofrin, this is a beautiful demonstration of collagen elastin. Some disruption with Foscan, it's a more powerful drug, so you would expect it to have more in the way of side effects. Blood vessels, here you can see the endothelial lining has been rubbed out completely, and these vessels are full of clot, full of thrombus. Does that make it dangerous? We've got some pretty important vessels in the head and neck. The carotid artery is quite useful if you want to maintain brain function. And we've actually looked at that. Will Grant, back in the 90s, looked at bursting pressures of PDT-treated sections of carotid artery and showed that the bursting pressures go up. That's to say, the mechanical integrity is not damaged by PDT. And that's true of large blood vessels. Alex Kubler later on confirmed the same thing. Now, I'm going to show you a series of graphs that show why we selected with Foscan the drug light interval, the drug dose, and the light dose. So here we are looking at this particular model. This is a slightly higher drug dose than we use now. This is the drug dose in skin, which you can see peaks at a couple of days and then drops off. Plasma, it's gone fairly quickly. And this is tumor tissue. So there is some selectivity between tumor and normal. Now, if you look at this 4-day period, there's quite a big difference between tumor and skin and plasma. So that's really why the 4-day drug light interval was selected. Later in the week, I'll be talking about some of the other applications where we treat much earlier, but this is the conventional way of using Foscan. The time interval, this is showing again that the time for maximal effect here is the difference between tumor and muscle damage is a nice differential at 96 hours. You could treat earlier, you could potentially treat here, but the amount of muscle swelling and muscle damage that you get is going to be very much greater. Light dose. As we increase the light dose, it seems to plateau at about 20 joules per square centimeter. So this is where we've chosen the light dose. And the depth of tumor necrosis increases with the amount of drug that you give. And we've, in fact, opted for about 0.15 in humans. So that's how we get our treatment parameters. Also, if you look at the intravenous administration, as I showed you earlier, the plasma levels drop off quite quickly. So by the time you're getting out to 24, 48 hours, the amount of drug in the vascular compartment has dropped. Now, you may want a vascular effect, and for some of the applications, we would actually be looking to treat very much earlier so that we do get the drug active in the vascular compartment. So these are pretty much the standardized therapeutic parameters. Drug dose of 0.15 milligrams per kilogram, drug light interval 96 hours, light dose 20 joules per square centimeter at 100 milliwatts with very specific wavelength of 652 nanometers for 200 seconds. Okay, clinical effect. I'm not going to show you very much in terms of clinical effects because I'm going to describe that more in some of the studies that I'll be talking about later in the week. Is it selective? Well, no. All of these drugs will damage tissue where you shine the light, and you get most damage with Foscan, second most with photofrin, and slightly less with ALA. ALA, you can see, has really taken off the epithelium. It's just wiped the whole of the epithelial lining off. And this is its strength and its weakness. It means that it's difficult to treat deep-seated tumors, but as we've heard about photorejuvenation earlier on, if you have a drink of ALA and you go out, take all your clothes off, go out in the sunshine, you'll turn black. I've done this to a patient, not quite as extensively as that, but I've done it around some operating drapes. You turn black, and after a couple of days, you just peel off the epithelial lining of your body, and underneath you look 10 years younger. So there's a big market in this, but I wouldn't recommend you try it at home. Okay. How safe is it? We've heard discussions about thermal therapies and thermal as opposed to PDT. Is there an advantage with PDT over thermal therapies? Well, I think the major advantage is this one. Does PDT damage nerves? Well, probably not. Kubler in a rat model showed that nerves are damaged to a small extent, but they have the ability to recover. We, in a clinical paper, found that we were able to treat close to the facial nerve and other nerves in the head and neck without causing them any damage. And the reason for this was elucidated by Phillips, who works at the Open University in England, working with the group in London at the laser centre where I am. And he basically showed that the nerves do not take up Phoscan to any significant effect. So if you want an advantage, got the advantage of minimal scarring. You get a lot more scarring if you use thermal treatments, and nerve preservation are two of the main ones. Also, the vascular safety is another important feature. Now, these are the drugs that are mainly in use, and you can see they all have different characteristics. Photofrin, blood-derived product, used at 2 milligrams per kilogram. I heard Ron say that he uses a lower dose than that, but this is the standard therapy. Light dose of 100 joules per square centimetre, 630 nanometers wavelength, drug light interval of 48 hours. Now, this is inconvenient in many ways. This light dose is a bit high, waiting around for 48 hours for the drug to distribute through the body, and 630 is a slightly shorter wavelength, so tissue penetration's not quite as much as we would like. ALA, quite large doses. It's a naturally occurring heme precursor. Again, 100 joules per square centimetre. Shorter drug light interval and a slightly longer wavelength, but still down in the red. Phoscan, small amounts of drug, short treatment times, long drug light interval, and a longer wavelength. Now, what this translates to in clinical effect, ALA will take out tissue down to a millimetre or two. Photofrin will take out tissue down to about 0.5 centimetre. Phoscan will take out tissue down to 1 centimetre or more. You pay a price for that. This is quite frisky stuff. From a surgical perspective, what do you think the most important line on this is? This one. It takes 1,000 seconds to deliver 100 joules per square centimetre. 1,000 seconds is a lifetime to a surgeon. Surgeons, you all know. How many of you in the audience are actually surgeons? How many have we got apart from Luke? Right. Okay, well, surgeons have the attention span of butterflies on crack. They really do not have time to wait around. So this is 200 seconds. So you can see there's quite a saving. If you have to treat with multiple sites, you multiply 1,000 seconds and you've got a very bored surgeon on your hand. In fact, at that stage, when we used to use these drugs, more often in clinical practice, that would be when I would go and have a cup of coffee and leave the resident to hold the fibre. Okay, so let's get down to, I was hoping to give you enough information from this to actually be able to undertake PDT in clinical practice. So these are the things I'm going to go through. Patient preparation. Now, in the UK and most of Europe, all patients have to go through a multidisciplinary meeting. So you get a room full of people, nearly as many as in here, really. You've got surgeons, head and neck surgeons from different specialties, pathologists, cytologists, radiologists, clinical nurse specialists, nutritionalists. Who have I left out? I mean, there's a room full of people. And each case is discussed. Anyone with a diagnosis of cancer is discussed at this meeting. And PDT has to be embedded in the MDT process, or else you'll never get any patients. There needs to be a detailed discussion of treatment before the patient is consented. So consent should ideally be taken before the drug is injected. As soon as the patient's had the drug injected, there's light restrictions that I'll talk about. And there are discussions about whether this can be done as an inpatient or an outpatient. Obviously, if you're occupying a hospital bed, there's a cost implication. So the more of this that can be done as an outpatient, the better. And this really is dependent on geography and whether the patients have got any family support. I don't know your head and neck cancer patients in Brazil. I don't know what they're like. A typical European head and neck cancer patient will have smoked in their lifetime 700 kilograms of tobacco, and they will have drunk 10,000 litres of pure alcohol. Now, I found a few bars yesterday, but I'd have to go some to get up to that sort of standard. Okay. So when you're preparing the patient, it's terribly important that any family members or carers are involved in the discussion so that they buy into the whole process. If you have a nurse specialist, and I've had one intermittently over the last 20 years, a nurse specialist is absolutely key in all of this process, in talking to the patient, explaining what the treatment involves, and making sure they're going to be safe. In an ideal world, the nurse could do a home visit. It doesn't happen. In our unit, it doesn't happen. The use of light meters, absolutely essential. How much light do you think you're under over that side of the room in lux? You're probably in about 20 lux worth of light over that side, and you might get up to 100 lux over this side. I doubt if you're even that high. Now, 100 lux is the amount of light we recommend a patient has straight away after they've had the drug. Day one light, 100 lux. So this concept of sitting in a dark room, which is frequently bandied about by our opponents and detractors, we have to sit in a dark room for 2 weeks, is rubbish. In fact, when we first started using Phoscan back in the early 90s, we used to keep patients in a dark room for a week or so. They were suicidal. They really were. I mean, it's very miserable being stuck in a dark room. So when we talk about these complex dermatoses, where patients are very sensitive to light, it is a miserable, miserable business. Lots of written instructions so that patients know exactly what's going on, and informing general practitioners or the family doctor so that they can give patients support. Right, okay, so actually giving the drug. Well, there's been some change in the way the drug's prepared, but let's stick to this. We did hear about Phoscan, that it's dissolved in an organic solvent, and that's important because that tends to be quite irritant to veins. So this is a simple schematic: inject the drug, wait 96 hours, activate. Now, this is the first problem. Drug administration. Because this is a strongly alcohol-based formulation, you have to give it into a very large vein. Nice big antecubital fossa vein, and you must make sure it doesn't leak out at all. Give it slowly. I don't believe in that. It hurts. It hurts like hell when you inject it. So why would you inject it slowly? I've never understood this. This is the recommendation of the Biolitech company. They say at least 6 minutes. I say at least 6 seconds. Inject it without flushing because it can precipitate. It's in an alcohol solution. So if you flush it through, it will precipitate. And you have to make sure that whatever system you're giving it through, you can account for the dead space. So you must allow for that dead space, especially if you're using a cannula and a filter. You can preload the vein with a tickle of lidocaine. You can put a squirt of lidocaine in, just as the anaesthetists do when they're using propofol. You can just give a little bit of local anaesthetic to anaesthetize the vein. I've sort of stopped doing that recently. I don't quite know why. It's just too much of a fag. And the injection site itself often remains photosensitive for several months. So although the patient may be completely back to normal, if they go out into bright sunlight 2 months out, they may well develop some ulceration around the site of the injection. Okay, so that's something you have to tell the patients about. If it does extravasate, then you need to keep the arm covered. I have actually had one major complication with extravasation. It was on a very well-known trumpet player. an American, needless to say. He'd come over for treatment to the UK, and he got quite a degree of extravasation, and his arm was swollen for weeks. It was a long time till he could get back to playing the trumpet. He still talks to me, which I think is quite miraculous. Overdose? Well, all of the initial studies that were done with Foscan were done with 0.3 milligrams per kilogram. We use 0.15. So the safety margin is enormous with this drug. The only thing is, if you do have a significant overdose, you've just got to be careful about the increased photosensitivity. I don't really believe that it'll get a deeper area of necrosis. I don't believe that's going to happen. Why? You can only kill tumour once, and the limitation is the penetration of light through tissue. Spillage. You should wash it off with soap and water, except if you spill it on a white shirt. This is another mistake I've made. You spill it on a white shirt, it's a dark brown colour, it will never come out. If you spill it on your shirt, you go to Marks and Spencer's or your local store and you buy a new one and throw the old one away. Now, before you give the drug, I should have put this in a little bit earlier, it's essential that you make sure that you have a laser and one that works. So you need to check to make sure that the laser is going to work. You can do this after, it depends where you are. In Europe, if you do a test the day before you're about to treat and the laser stopped working, you've still got time to get one brought over by car or something from Germany, or borrow one from another hospital. It might be a bit more tricky here. You've how many 652 lasers have you got that work? Yeah, okay, so it's a bit longer than the 4-day drug light interval. Okay. Light restriction regime, as I said to you, 100 lux from day 1 and then increasing by 100 lux through to about day 14, and then patients can go outside into some sunlight. Of course, they can go out into sunlight if they're covered up straight after having the injection, and this is important when scheduling the treatment itself. If you're going to treat on an outpatient basis, we tend to give the injection, usually it's a Friday, Tuesday algorithm because that's our operating day on a Tuesday. So we'll give the drug on a Friday, usually when Luke's on call so that he can give the drug about 5 or 6 in the evening when the sun's gone down, and then there's not too much of an issue. But leaving the hospital on day 1 is a time that you have to be careful because the patient is at their most light sensitive. And as I said, this does not mean total darkness. TVs and computer monitors are fine. Gradually increase the light exposure. Compliance is not generally a major problem. Most of my compliance issues have been in patients who have been supervised in hospital. Patients who are not quite, their attention span's not great. You know, if you've drunk all that alcohol during your lifetime, your cerebral function's not that great and your memory's not so good. So leaving an elderly patient who's had PDT in a chair as the sun comes round is a bit of a disaster. So the ward staff have to be educated, I think the word is. So compliance is not a major problem. Ron's comment earlier on that if the patient laughs at your comments about light avoidance, then that's the time to read them the Riot Act and tell them that you are not interested in treating them. Photosensitivity reactions, when they do occur, are usually mild, usually the hand, nose, they're usually self-limiting, something like this. Some of them are a bit more extreme, and I'll show you in a bit some of the more serious ones. So reinforce the light regime. Sunblock gives you little or no protection. And the common errors are usually when you've got an overcast day, you're in a car for a long period of time, and there's quite a lot of light shining through, and this business of travelling to and from hospital appointments has to be taken quite seriously. Now, the process of illumination. Here we are, demonstration of an outpatient setting, illuminating the side of the tongue. We use a microlens system here to make sure that there's even dosimetry of the light across this area that we're treating. So the microlens produces a circular spot, This is the simple calculation that 20 joules at 100 milliwatts takes 200 seconds, and this depends on the output of your laser as to how big a spot you can treat. Now, if you're treating something on the skin, that's usually a piece of cake. It's a doddle. It's easy to get to the skin, and what you don't want, you've got all this scattering and reflection, what you don't want is to have, sorry, it's this one, you don't want to have the light coming in at an angle, because then you get lots of scatter and reflection and you get uneven light distribution. What you want is light being delivered at right angles so that you get this top hat kind of light distribution to make sure it's even. Now the mouth is not a very flat area. A lateral border of tongue, okay, you can pull that out, you can flatten it out and you can get it straight. But often it's better to use multiple small spots so that you can get round some of the awkward geometry in the head and neck. And exactly the same as surgery, you completely illuminate a tumour area with a safety margin of 5 to 10 millimeters, depending on your normal surgical practice. Sometimes it's difficult to achieve that. The choice between local anaesthetic and general anaesthetic. I was interested in the discussion earlier on about the effects of general anaesthetic on PDT. I have been blissfully unaware of this possible complication for 20 years. I've not seen it, fortunately. But really, the difference between local and general anaesthetic is driven by all sorts of things. It's driven by the ability to expose the whole of the tumour, and we sometimes have to use endoscopes, we use retractors, sutures, and you couldn't do this sort of thing treating at the back of the mouth. You couldn't do this sort of thing under local anaesthetic. It's just not practical. So it's good for exposure. It's good if patients have got a very vigorous gag reflex or swallowing, or if they've got any conditions like Parkinson's where they're shaking quite a lot. And unless you've been to the pub the night before and you're shaking in harmony, it's a problem. And sometimes local plus sedation may be an alternative. Now, if you are going to give a general anaesthetic, there are a couple of little tricks. First of all, we heard about pulse oximeter burns. The pulse oximeter is a red Heaney laser, and it just causes these intensely painful ulcerated blisters just over the nail bed. They are exquisitely painful. The other thing is that when you're operating under general anaesthetic, we're all wearing our safety glasses. The glasses are blue to filter out the red light from the PDT. Okay? And what are all the monitors configured in? Well, all the dangerous numbers are all configured in red, so if you put your glasses on, you can't see them. And it's worse than that, because all of the drugs in the EU are colour-coded. They're different colours for muscle relaxants compared with sedative agents. So your anaesthetist needs to be aware of this factor. And Miriam Chapman and Vicky Mitchell have been my anaesthetists for the last 20 years. One of the things that's also terribly important is shielding of normal tissue. We've spoken about the potential for this to give you a selective effect. Now, I don't believe that it's with these treatment parameters, and I emphasize that with these treatment parameters, I don't think that selectivity is achievable. But we do minimize the effects by shielding. This is black wax, which is terribly easy to use. You just warm it up, bend it to shape, cool it off, and you've got the exact area outlined. You can use dark surgical drapes. Of course, now we can't because all of ours are disposable. But here, this is the Dutch group. My colleagues in Holland have done quite a lot of this stuff. Black wax, I think they were the ones who developed it. So shielding is terribly important. You can get really exotic if you've got access to a dental technician. You can make vacuum-formed black splints so that you can just leave the area you want to treat uncovered. That allows you to use big spot sizes, and then if you move a little bit, it doesn't matter, because as long as you're treating a wide area here, you can't have an effect on the black plastic. There are all sorts of other shielding things you can do. Around the necks of the teeth, in the oral cavity, that's a very difficult area to treat. And it's difficult because of the periodontal attachment of the teeth, and to have something like this that just protects them wherever possible is useful. Sometimes the teeth just come out after PDT. You destroy the periodontal ligament, they get loose and they come out. So, cancer, loose tooth. Okay, it might be worth it, but it's worth mentioning to the patients. So how important is shielding? Well, this is a case that was done without shielding, treating this area of dysplasia here, an early cancer. This is an area that was treated with shielding. And just remember, when you're shielding, this is a case of a retromolar trigone tumour here that was treated with shielding. And you can see there's quite a nice localized effect there, really quite good. Didn't shield the lip. This is where the fibre passed over the lip, and this is what happened to the lip. So just be aware that shielding requires a bit of thought. Fortunately, in a couple of weeks, everything's completely back to normal. Tumour's gone, lip looks half reasonable. So they got away with it that time. This wasn't, I won't tell you whose case this was. It wasn't one of mine. My complications are much worse than that. Now, just like surgery, this is painful. This treatment hurts, particularly with surface illumination. Surface illumination treatment requires a lot of analgesia. We tend to use opiates. We tend to use fentanyl patches, and you may need to carry that on for quite a while. Sometimes, if you get big lumps of necrotic tissue, you may need to debride those and cut them away. So, this is our analgesia regime. When we actually do the treatment, we use dexamethasone to reduce the swelling, use MST, non-steroidals, fentanyl patches, diclofenac. The patient gets what they need, and their requirements can be quite extensive. Support measures. Well, you need staff that understand. You need the ward properly equipped. Everyone needs to know what you're doing. Liaison nurse, worth her weight in gold, or his weight in gold. But ensure that the whole team is involved. If you start launching a standalone head and neck service for PDT within a head and neck centre, and I'm sure this equates across the other specialties, then everyone will deny responsibility for looking after the patient. And over a weekend or a bank holiday weekend, that can be disastrous. That really can. So it's essential. I can't claim that we have brilliant team working in all of our centres. So it is difficult, and I have seen problems as a result. Dietary advice, well, we rarely need to nasogastrically feed patients. Some of the more complex treatments require nasogastric feeding, but soft diet, again, this is a counsel of perfection, home visits from the liaison nurse. Sometimes we treat in very sensitive areas. Now, the most sensitive area that we treat is tongue base. Treating tongue-based tumours, we have to be very mindful of airway management. And there are a number of different ways of looking after the airway. A standard tracheostomy, this is a Cook airway exchange catheter. This is a quick track, and this is a mini track. So there are a variety of things, but you really need to have a discussion with your anaesthetist about how to manage airways. PDT doesn't kill patients. I'll show you a case where it has later in the week, but broadly speaking, PDT doesn't kill patients. A blocked airway will, sure as eggs are eggs. Now, up to now I've been talking about surface illumination. Surface illumination's fine, but you're limited by the depth of penetration of the light, which is about 1 centimetre. So why not stick the light into the tissue? Seems logical. We did some Monte Carlo modelling to see how light is distributed around a bare fibre tip, and then looked at different patterns and distribution of light to make sure that we had confluent light sufficient to cause necrosis. So this is looking from the top. We put our fibres on a triangular or a diamond-shaped grid like this, and then we treat at this level, and we use a step-back technique so we can treat a volume of tumour. The alternative is to use diffuser fibres, which will treat over a longer length. And this again is the Dutch group. They've been doing a lot with interstitial techniques using radiotherapy planning techniques, where they put in after-loading devices, which they then load with diffuser fibres to treat tumours, particularly like this at the tongue base. And this is radiotherapy planning, but it could just as easily be optical planning. You can calculate your light dose to make sure that you are delivering sufficient light to the whole tumour volume. As I said, we've used a point source, and we made this in the very early days. We used this anatomical grid. This was my snooker rack. Okay, anyone play snooker? No, okay. It's the shape of a snooker rack that you use for racking up the balls. Do it in pool as well. And it's got precision drilled holes that are exactly 1.5 centimeters apart. And then we use this to guide the needles through that. And then we load the needles with our fibers. So this is the fiber optic coming from the laser. It's flagged so that we know that when the flag is against the hub of the needle, we know that the fiber is just poking out the other end. So we're actually delivering light into this tumour. So we'll treat down here at one depth, then we'll pull back a centimetre, treat at this level, then treat at this level until we've treated the whole of the tumour volume. You can use image guidance. Here we are in an MR scanner. Must remember that if you're in an MR scanner, you have to use titanium needles. Stainless steel needles don't fly around the place too much. It's rather like water divining if you use a stainless steel needle in a magnetic field. It's a bit scary, but it doesn't matter. It just gives you useless images. You can't see anything on the images. But we've done some like that. We've done some under direct vision. In the same way, you can use CT, MR, depends on the nature of the tumour. Most recently, we've been doing a lot of ultrasound-guided treatments, and this is very much simpler to achieve. You go into the operating theatre on a standard operating list. You get the radiologist to come in, wheel in an ultrasound machine, and he can put the needles into a tumour volume, which you've predetermined on the MR scan. And this is a very simplistic, quick way of doing the treatment. So this is one of my favoured areas of treatment is tongue-based tumours. So if Michael Douglas does get a recurrence after his radiotherapy, we'll direct him for some PDT. You're staring down the barrel of a gun with tongue-based tumours. If you fail chemoradiotherapy, which is treatment of choice, if you fail that, you're looking at a fairly mutilating operation to remove the whole of your tongue, probably the larynx as well, because you'll have an unsafe swallow. And that's probably for a 20% 2-year survival. It's not good. So if you're in that situation, then we're able to offer therapy for these patients and leave them with their speech and some degree of dignity intact. Head and neck cancer, as I said to you, is a loco-regional disease. So the tumour will spread from there to the glands in the neck, the lymphatics in the neck, and you can, in the same way, you can treat those with interstitial treatments with PDT. So that is really an idiot's guide of how to actually do the treatment. I guess that those of you who are not clinicians will find this a bit abstract, but there should be enough information there for you to actually pick up a laser and treat someone if you wanted to. Later in the week, I'll be going into some of the specific studies and showing you lots more pretty pictures. I guess if you're not clinicians, they might be a bit scary. Yeah. Thank you. Cheers.
Have you been seeing different photosensitizer concentrations, comparing different anatomical sites in head and neck, like oral cavity or...
Okay. For most of the cancer treatments, the treatment parameters are fixed. Now, whether they're fixed at the right level is a very different question. So I'll be talking about skin cancer treatment with Phoscan later in the week. And there we've actually gone from 0.15 milligrams per kilogram and treatment at day 4 to 0.04 milligrams and treatment at 24 hours. And it works. And it works really well. Obviously, there are benefits in there's less drug use, so the cost is less. There's less phototoxicity. There are all sorts of things like that. I remember saying, in the old days of Scotia, who developed this drug, I remember saying to them, okay, so the plan is to get this drug a license and then we find out how to use it. And I'm afraid it's very much like that. It's very difficult to do anything that's not a licensed indication nowadays. It's becoming harder and harder. But I'm sure you're right.
And also considering mainly for the interstitial applications, do you have a customized dosimetry for each patient, or it's a standard illumination
It's
energy?
pretty much standard illumination. My radiologist has become a bit wilder as he's got more practice, and he's putting lots more needles in. We're getting more swelling after treatment. I'm not sure that I've really seen enough to tell whether patients are living longer, but it's certainly out there.
Hey, so I knew nothing about PDT before coming to this conference. I work with diagnostics, so this might be it is an ignorance-based question. You showed the image of the lip of the patient who was exposed due to poor shielding. And I don't know if it's because it's a photo op, but all of the images that I've seen of the devices show a red fiber going to the patients. Why not use a jacketed fiber to protect the patient from light getting to places you don't want it to be?
Yeah, that's a perfectly reasonable thing to do. I don't understand how that happened, quite honestly, because I've never seen it myself. I do tend to just simply putting some gauze over the lip is usually enough just to prevent too much of an effect. But you are absolutely right. There are certain situations, particularly with treatment of nasopharyngeal cancer, and I treated some tumour going up the eustachian tube, which was quite bizarre, where we used a sleeve to make sure with a long diffuser fibre that we only delivered light to where we wanted it. That was slightly different because the sleeve was actually over an active part of the fibre. I'm not quite sure how they managed to do that to a lip, but we usually just put something over just to protect the lip. And of course the cost goes up. You get miles of these fibres for virtually nothing. As soon as you put an end on it, a microlens system on it, the cost goes up dramatically. I'm sure it would.
That was a good talk. Are there any other lifestyle? Are there any other lifestyle effects that are any changes in lifestyle that you recommend after a procedure? Like, so if I work out, can I work out again immediately afterwards, or are there anything other than going out in the sun that?
I think that sounds like a very simple question. It's not quite that simple an answer. I think to some extent it depends on the extent of the treatment that you do. And if you do very extensive treatments, and I'll show you, where you're treating tumours of this kind of volume, all that dead tissue releases a lot of TNF and a lot of all sorts of other bad stuff in the cancer cells, which has a systemic effect. And you will often find that for 2 or 3 weeks, patients they'll have a leukocytosis, let's say their white count will go up, and they'll have a flicking pyrexia, not anything very dramatic, but just enough, and they'll feel a bit flu-like, they'll feel a bit under the weather. I don't think there's any absolute reason not to go to the gym, not to go swimming. Obviously, if you treat skin cancer, you might want some sort of protection over it. In those sort of lifestyle terms, I don't see a major problem. Sunbathing, of course, is a major problem, and I take the attitude that should be discouraged anyway. Smoking cessation programs, again, common sense. You don't want the patients to continue to feed their carcinogens into their system, so you need to get them signed up into alcohol and smoking awareness campaigns and things like that. I can't think of anything specific if they feel like it.
Oh, and if I can ask this question. When you're performing a new procedure, could you talk about, I guess, like the governing body that kind of dictates what new procedures you can perform as a surgeon using photodynamic therapy?
Yeah, when we first started doing this, it's all been going on for 20 years. And when we first started doing this, it was relatively easy. The ethics process was quite straightforward. And I actually, by the 90s, I'd got established with an interstitial PDT program. In the early 2000s, I'd extended it to non-malignant indications, done all sorts of things. More recently, we've had a slightly aggressive change in management. And the management, that we've got a manager who doesn't think that PDT's a very good thing. She's from a nursing background and she's a manager. And I get letters from her talking about non-malignant skin cancers and stuff. So she's got absolutely no idea, but she's decided that I can only use PDT for the licensed indication, which is the palliative treatment of advanced head and neck cancer. And if I do anything that's outside of that remit, that's off-label, I have to fill in a 5-page application that gets sent to a purchasing health authority in the UK. It takes a long time. So we are getting increasingly tied up in red tape. And it's one thing for me to know how to do something, but even I have my own problems. Talking to Bing Tan in Amsterdam, he's another big PDT expert. He's done an awful lot, and he said that he's finding it's getting harder to do stuff. And the pressure, which I rather cynically suspect comes from major pharmaceutical industries, the pressure to marginalize PDT is constantly there.
Hello. As far as I understand, in PDT, only the cancer part was specifically illuminated to kill the cells, and the whole body gets photosensitive. Why don't we just inject directly the photosensitizer to the cancer and illuminate it, so it will be avoid the whole body?
Yeah, that works with ALA, treating actinic keratosis and things on the surface. To get these drugs into the tumor is not currently possible with direct injection into the tumor tissue.
So we can combine with the surgery.
Yeah, I've not been aware that any of that's worked. It works with ALA. There's no question. You can actually debride. You can pare down a basal cell carcinoma, put the cream on, and illuminate that, and that's a very localized effect. And I guess if you're talking about new drugs, you want drugs with short drug light intervals. I mean, 2 CAD's only a matter of, I think, 11 minutes or something. It's a very short drug light interval. It's very much more of a vascular effect, which is not particularly what we want for some of these head and neck indications. Yeah, I would like to think we could get to that, but we can't do it at the moment.
Okay, thank you.
Hello, that was a very enlightening talk. I have a couple of questions. Firstly, do you do multiple light irradiations at any point of time if the first one doesn't show any good results? And this is especially for head and neck cancer. And if yes, do you see any secondary immune response?
Okay. The first part of the question, sorry, the second part's easier. Let's deal with the immunity bit. When we first started doing lots of interstitial treatment, and this started off, I think the first one was 1997, okay? We treated some of the most unbelievably hopeless patients we didn't think were fit for a haircut. And our median life expectancy in that cohort of patients, which we published, was 14 months. And funny things would happen, like one woman came to us saying, I won't do the voice, that she came to us saying, all I want to do is make it to my 60th birthday, which is in 3 months' time. They tell me I've only got weeks to live. Okay, she was sent home to die. And we treated her. And she made her 60th birthday and said goodbye to all of her friends, and was rather embarrassed a year later when she had to say hello again to all of her friends because she was still alive. Now, she died shortly after that, but we did see some really quite bizarre, really unexpected results. We showed in some of the early work we did with photofrin that there's an eosinophilic cell infiltrate at the base of the PDT-treated area in humans. And I was busily asking people, this is 1990, this is 20 years ago. I was busily asking pathologists, what does this mean? And they said, I don't know really, but it's associated with a good prognosis. So something PDT related is resulting in some sort of epiphenomena that's sort of systemic. And the advent of PDT vaccines is also somewhere out there. People are talking about them, and there's stuff going on. I for one, don't understand it, but it's working on our side. Multiple treatments. Yeah, you can treat with you need at least a month between treatments, ideally, otherwise you get into trouble with the phototoxicity, you don't quite know where you are. I did treat one patient who was obsessed with the idea that he hadn't got enough drug in his system. You do get some very strange patients. So we gave him a second dose. So we gave him a second dose of drug, I don't know, a few days later. So he certainly had plenty of drug on board when we treated him. So you can give, as I say, you could give 2 lots of drug on successive days, and you'd still be up to the maximum of 0.3 milligrams per kilogram, which is what the first studies were done with. So you can do that. Otherwise, you really want to try and evaluate the response. So my working philosophy is you treat a patient once, and then I almost let the patient decide on a cost-benefit ratio whether they're spending more time out of hospital than in it, for example, the clinical benefit they get and how long it was till they felt well, how long they felt well for before they deteriorated, before offering a second treatment. It's easy if the time interval between things is, say, a year. That's quite straightforward. You say, okay, tumour's growing again now, chap, we better treat you again. That's easy. Somewhere in the middle, there's a cut-off between patients saying, nah, that's so miserable, I'd rather not bother.
Sorry, I have another question. Is there who does the designs for your delivery system, for your light delivery system? Is there a physicist in the room sitting there making sure that?
I work closely with the med physicist. I didn't put the list of people I've got to thank up there because it's so long, it's unbelievable. But I do have a medical physicist who prepares all the fibers for me and sends them off to be ethylene oxide sterilized and gives advice about laser maintenance and all of that sort of stuff. So we basically have a choice between using bare tip fibers, and our laser will deliver 4 at once, so we can treat quite large volumes of stuff. Some of the newer lasers are 6-channel at 652. Some of the 2CAD lasers, I think, are 8-channel lasers. So there's the laser machine that you usually get given if you buy enough drug. And then you have a choice of how to design your treatment, be it with point sources or be it with diffuser fibers. So all these things are available off the shelf, and you just work out how much money you've got and what you're going to do. Because each of the diffuser fibers is a couple of £100, so about 500 Brazilian. So if you're doing 4 of those at once, that's £2,000 worth of consumables. And if you damage the fiber, you can only throw it away. So that's why we tend to use point sources, because you can buy a couple of miles of fiber, and it costs very little.
A technical question. When you do the interstitial, you put the diffuser directly into the tumor, or you do have a kind of transparent case?
You've got 2 choices. With interstitial treatments, you either use a standard spinal needle that shows up really nicely on ultrasound, and you flag that with a bare tip fiber, so the bare tip just pokes out through the end, so that you know that that's delivering light straight into the tissues. When it comes to the diffuser fibers, I use things like abocaths. I don't know if you've come across those. They have metal insides, but they're clear plastic sheaths, basically. And there are some that are hybrids between needles and conduits. So you put one of those in under ultrasound guidance, and then you feed your diffuser fiber in through the middle. So the diffuser fiber doesn't actually need to come into contact with the patient if you've got the right bits of kit.
Okay, thank you, Professor.